The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBRS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Solventum Prevena Therapy and Mammatome Breast Cancer Diagnostics and Surgical Solutions.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
At Mammatome, we offer a comprehensive range of products that deliver better outcomes in breast care. From biopsy to surgery, our advanced technologies empower clinicians with precise, trusted solutions. Together, we will transform the future of breast care. Learn more at mammatome.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast wherever you listen to podcasts.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
I went to Tractor Supply today and bought a chainsaw.
And we were all in St. Bart's. It was a rejuvenating.
no one's going to die because we take a week off, or even, God forbid, 2 weeks.
I have two different types of vacations. I have where I completely unplug.
Our topic today is MRI. Who, when, why?
I think everybody's going to know that I'm going to bash MRI here. So
I do a lot of oncoplastic surgery, and especially when we're moving stuff around, it's very hard to go.
It increases the rates of mastectomy.
Patient sometimes comes in saying, it's everywhere, take them both off.
I wonder if we're not causing more people to get mastectomy for whatever reason.
I love kind of walking people through the thought process of like, okay, so tell me how an MRI is going to change. I do think it's also important to discuss with our trainees and our patients that MRI.
How many of you guys use MRI to work up nipple discharge in the abs?
Michael, how often would you order a ductogram?
Typically, my go-to on a pathologic nipple discharge.
This is Carla.
Ellie.
Michael.
Susie.
And Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.
Our topic today is MRI. I'm not sure if it's one of the more loved or more hated topics to discuss, but it is always controversial and full of different opinions. But before we start, let's get to some personal and professional updates. Michael, let's start with you. What's going on the farm?
Well, thank you for asking. I went to Tractor Supply today and bought a chainsaw. So now I'm going to be branching out into lumberjack mode. I assembled it. There's an oil mixture you got to put in it, and I will now be cutting down trees and limbs and things like that. So updates will come as I saw through the forestry on my farm. Carla, tell me what you're farming.
I think we lead slightly different lives. So I actually just got back from vacation. I went on vacation with my family. So it was my parents, my brother, his wife, and 3 kids, and we were all in St. Bart's. It was a rejuvenating, beautiful vacation with family. We spent a lot of time in the water and just sort of soaking up. So I'll tell you what, I feel like my cup is full. I came back to work last week and I told people, hit me with what you've got, because I'm in a good mood.
St. Bart's is one of my favorite places. It's just unbelievable there. Everything about it is awesome.
I come back from vacation wondering when I'm going to retire.
Is that the farm vacation?
No, I don't vacation on the farm. I lumberjack.
Okay, so I've been to St. Bart's before. It is absolutely lovely, and I'm completely done after like a couple of days. I need a little bit more in there. And Michael, I'm just thinking, I'm a level 2 trauma surgeon, and we want to keep you all in one piece with a chainsaw.
Listen, I'm a surgeon. I'm used to cutting things. This is not a big deal.
So anyhow, make sure you have appropriate networking so that you can continue to be our president and operate.
Yeah, he's done with presidency shortly. Eric Manahan's ready.
Usher me out yet.
Well, I have continued running. I realized in a previous episode, I said I'd almost lapped 3 years. And I'm like, what am I thinking? It's been 4 years. I had a couple beautiful runs this weekend before I went snowboarding. Ellie, what's going on with you?
So I actually just came off of vacation as well. I did not go to St. Bart's. I've never been, but I've heard incredible things and it's definitely on my list. But I went to Joshua Tree and I brought 5 of my oldest girlfriends with me, and none of them are in medicine. So it's always nice to check in with old friends. And we were kind of glamping essentially because we'd go out and hike and then come back and we'd still have showers and hot running water and all that. You guys were talking about before, my cup is a little full. We have a lot of full cups, and it's just always amazing to unplug from work. I'm getting better at that. I didn't answer my Epic chat every day, so that's a move in the right direction. And it's just always good to take those breaks from medicine at times. And yeah, I can't complain. It was a wonderful trip. Susan, what about you?
What is this Epic chat that you speak of? Is this patients or your staff?
You don't have Epic, Susan?
No, I've been on Epic and we're going to Epic. But my feeling on this is I greatly respect my staff when they're on vacation, and the thought of texting them or emailing them would not cross my mind, or calling them. I do think that it is our responsibility to inform them that they need to do the same. No one's going to die because we take a week off, or even, God forbid, 2 weeks off. Michael, who's the dad of this group, has taught me that. He's a lot older than me, and we all learn from each other. But in order to come back charged and refueled, you need to disconnect. Now, if you want to check in once a day, that's okay. But you say, you'll hear from me at 9 a.m. I'll answer your questions, and that's it. But you really do need to stick to that, if that's even what you're going to do. I mean, Carla, when you go away, do you completely unplug?
I have 2 different types of vacations. I have where I completely unplug, and I have where you can reach me because it's going to be easier for me when I come back from work. So St. Bart's was a completely unplug, and I set up all the parameters ahead of time that you can't reach me unless there's an emergency, because that's really important to me. The trips where I'm still engaged a little bit when I go visit my family sometimes, or I have to spend some time on the East Coast, my dad's having surgery again. So those types of things I will engage a little bit. But no, on St. Bart's, I read some great books. I'm happy to talk about that, although I know we probably need to get to MRI, but love disengaging.
So whenever I'm out of the country, my Epic doesn't work. So I am my own worst enemy. Sometimes I'll put it on the last screen on my phone, or I just take it off. But I have a message on there that says I'm out of town. But what I love when I get back is it links to the patient. It has the whole conversation I could follow that everyone else has already taken care of. So I'm up to date in about 30 seconds without someone having to debrief me on every little detail on there. So I actually love Epic chats, and it's my responsibility not to engage in it, but my staff knows when I'm gone.
I have a couple of questions for you guys then. So one, all of my partners, 5 of them, they all engage in Epic chat 24/7, even when they're on vacation. So that's one challenge, is when I try and put those little things in place like you're talking about, but every other surgeon responds to them. So that part is really hard. And then the second part, I did kind of unplug this time. And then the day I came back, horrible. I had so much to do.
Unless you have like 4 hours before you start your day. Otherwise, you need a vacation from your vacation just to catch up on everything.
And that's why it's okay to say, I'm doing this a little different than every other surgeon in the group. That's okay. You're a leader. You are going to start the change. There's generational things. And listen, I wish I followed my advice. So let's take this with a grain of salt. But I want better for everyone else than I do for myself. And I really, really think it's important to unplug. And let me tell you, if I don't remember, my kids remind me. But let's move on to our topic of the day, MRI. This is discussed constantly in our tumor boards. It's really incredible. I have one view and several of my surgeons have the totally opposite view that every single patient, every single day is worthy of an MRI. So let's talk about this. MRI. Who, when, why? In the world of breast surgery, breast MRI is not meant to be routine for average risk women. It's a supplemental tool. Do we need to be doing this every year? It has contrast. Is it used as an adjunct to mammography? How are we using it? When? Every neoadjuvant patient, do you get an MRI on? And then how often do you follow that? Ellie, how do you handle neoadjuvants? Let's start there.
Sure. So in my current practice, I have very easy access to all the imaging and I can get it very quickly. So I do utilize MRI quite a bit. I get it in every cancer patient when I'm working them up, and I also get it at the end of neoadjuvant. I don't get it in the middle of neoadjuvant. If we see it on ultrasound, I'll follow it on ultrasound or something for a mid-check.
Just because you have access, does that mean everyone gets an MRI? Is that a good enough reason? Or are you following data and guidelines and protocols as to who should get it and who shouldn't?
The neoadjuvant patient is really one of the highest planned patients that I operate on. I'm thinking about the disease response and what I'm resecting and everything. So especially there, I am hypercritical on my imaging. And that's just my current practice. Maybe someone just had calcs that we could see. Did they need it?
But you get it, whether they need it or not. You get the MRI.
I think if anybody kind of knows where I fall these days, I think everybody's going to know that I'm going to bash MRI here. So I will play devil's advocate. Ellie, you probably do the most oncoplastic surgery of this panel as well. Do you think you use MRI more frequently because of the oncoplastic surgery?
What are you trying to prevent, Ellie, by getting it on every patient? You're obviously concerned about something or you wouldn't order it. What is it you're concerned about?
Missing a piece of disease.
Do you think it's relevant?
I do, yeah.
What was the original MRI study? What did it show? What percentage did we pick up of cancer? 4%. 4%. That included things that weren't biopsied that they thought may be cancer. 4%. So you're going to get an MRI on everyone. And that 4% in that original study was a millimeter larger than we thought. You're getting an MRI. Contrast, do we really know what gadolinium in the brain means or doesn't mean?
That is a valid argument. And I think gadolinium in the 2000s, it was big, it was chunky, and finding it at autopsy. And it has been reformatted where it's smaller. Is it still probably there? Yes. Do we know that it all gets excreted? No, it doesn't. But is it harmful? That hasn't been proven yet now that they've reformatted it.
Hasn't been proven that it's not harmful either. Every time I send a patient to MRI, I tell them, listen, this could show up. We don't know what it means, but I feel obligated to tell them that.
We have now over 20 years of data with that.
I've learned a fourth trial. Alliance 11104 presented at San Antonio, and it asked this very question on high-risk breast cancer patients. So they were either HER2 positive or triple negative. They were all hormone receptor negative. And it asked the question, should standard MRI be part of just the workup? And so they took 300 almost 20 women and split them up between standard imaging, mammography, ultrasound, physical exam, and they took the other half and they added MRI. 85% of those women, because they were high-risk cancers, 85% of those women got chemotherapy. And they kind of shifted a little bit because when they first started it, Keynote 522 wasn't really out yet, and they shifted it over. So about 18% eventually got neoadjuvant chemo, and about 64, whatever makes 85%, got adjuvant chemo. And at 5 years, there was zero difference in local regional recurrence, no overall survival difference. And these are patients that were high risk, so they should have come back in that 5-year span. So their point is, Alliance trial basically is saying, hey, look, you just should order it on any patient that has a cancer. Now, again, there are stipulations, obviously. The BRCA patients were excluded. What you described as, I got a breast cancer patient and I'm going to get an MRI, that's why I asked you, what are you trying to avoid? Because local regional recurrence shouldn't concern you anymore. Overall survival shouldn't concern you anymore. So is this not compelling to make you change your mind?
I do think that's a compelling paper, but I revise my statement that I get it on absolutely every patient, because I don't if they're old or just certain case by case. But I do a lot of oncoplastic surgery. And especially when we're moving stuff around, it's very hard to go back. And again, I'm early in my practice, so I'm pretty cautious to get rid of tools that have helped me in the past find areas that I might not have biopsied before or taken out. MRI has pulled up stuff that I've taken out at the time of surgery.
The question always is it biologically significant? So I think that we've fully picked on Ellie enough. I'm normally picking on Michael, but Carla, tell us about the studies that have changed overall survival and changed local recurrence and changed all that. Because if Ellie's getting it on every patient, there has to be a lot of studies showing us the benefit. I mean, it's got to be enormous benefit to get it on every patient.
And that's an easy answer, right? Because there's no trials that have shown a benefit in overall survival or local reoccurrence rates. And the big thing is, what does MRI do? It increases the rates of mastectomy. So it is tough. Yeah. I would say it would be interesting. It would be nice if we were able to pull that data very quickly and look at every single surgeon's MRI usage, because it shouldn't be zero. It shouldn't be 100%. You know, we're talking about, for the most part, diagnostic MRI. I think when we look at screening and diagnostic, we look at the criteria differently, although there's arguments to be made. But what's the right rate of MRI? If you're getting MRIs in 75% of your patients, is that too much? Probably. 50%, is that too much? Maybe not. Maybe the 25 to 50, but I'd be interested to hear Susan and Michael and Susie as well. What's the right rate of MRI? What's the range?
I don't have a right rate, but I want to say, actually, I think it can also decrease the rate of mastectomy as well, because a patient sometimes comes in saying, it's everywhere, take them both off. And we have another adjunct to be like, no, there's not something on the other side. And it can be used in that way as well.
Right. So this is, I saw that patient 6 months ago and I remember I got an MRI and then we didn't do a bilateral mastectomy. That's not how we can practice medicine.
It's not, but we actually have done studies at our own institution looking at how many times do you have a false positive, how many people find an additional area that needs to be worked up. And out of that percentage, how many need biopsy and how many times is that a cancer? It was 30% at our institution.
I worry about that. I worry about your standard imaging then. It shouldn't be 30%. There's no study that shows that it's 30%.
But that we wanted to know what it was locally.
Saying that when there's an additional finding on MRI, Susie, that 30% of the time when you biopsy, that is an additional cancer. Not that there's the MRI shows cancers in 30% of patients. We usually say the false positive rate is 20% or so.
30%.
We repeated it and then watched how the false positive rate went down over time as we've gotten better with having 3D tomosynthesis, or how we are reading the MRIs. We can see that with the diagnostic, we tend to do breast density type D, and we tend to do it in lobulars in younger women. And again, it's not going to change. I think it has been a better guide and help people know a little bit more about staging up front. I've seen a lot of lobulars be upstaged.
Can we define younger and older? I know we use these terms all the time. Susie, you just said younger. Ellie, you said older. What do we mean? Are we talking about 30-year-olds and 80-year-olds? I never quite know. I was interviewing someone for fellowship the other day and they said older. And I said, oh, what age? She said 45.
Oh my gosh. A patient that I see that is under 50, I don't always get an MRI, but I always think about an MRI. Any patient I see that's under 40, for the most part, I'm going to get an MRI unless it's really not going to change my surgical management, because many of those patients are going to be getting bilateral mastectomy, not all. But I feel like the data we have on mammography in women under 40 is much less so.
Frequently dense.
Yeah. And then you've got the 40 to 50-year-olds where clearly the women that are closer to 40, the women that are closer to 50, I may or may not, but age is never just a criteria. It's just I'm going to look at their histology. I don't get it on all patients with lobular, but I definitely get it on well over 50%. I look at their breast density, but if they've got fatty breast, a small 1 centimeter tumor, and they're 41, for the most part, I will just use the mammography and not just get an MRI based on that.
Totally agree with that. And I think also age is physiologic, Susan. So you can have a 70-year-old who's totally rocking it and a 70-year-old who has really big competing comorbidities. And so we are looking at the whole patient.
But to support what Carla said, and it's a 30,000-foot view and it's multifactorial, but when you look at the curves for MRI use, it almost mirrors the curve for mastectomy, right? And you can't say it's necessarily cause and effect, but they mirror each other. So I wonder if we're not causing more people to get mastectomy for whatever reason, anxiety, or you found all these other things, and I don't want another biopsy or whatever else, that I'm not saying stick your head in the sand, but again, back to the clinically relevant. What if that stuff goes away with treatment, with radiation or chemotherapy or endocrine therapy? If it doesn't, you ought to see some differences in local regional recurrence. And if we don't, and again, these were high-risk patients, you're going to have to drag it out longer and to do a different study for our hormone receptor positive patients. But I don't know. It was going to be the test that answers all tests. And I think we should really use it judiciously.
I have some patients who come in, they are set on mastectomy. I 100% say do not get an MRI. If there is no information that's going to be gained from that, they do not need that test.
What about their other breasts? Just playing the devil's advocate.
Right. We have a lot of patients who come in insisting on a bilateral mastectomy. We can do all the education. We can go through everything, and we do it every single time for completeness sake and try to figure out why they're presenting with such a conviction for that. And if they're presenting for that conviction, they've heard the other information, they do not need an MRI.
I think most patients don't need an MRI. I think for some patients it's helpful to get an MRI, but I think there are the rare cases where people really need it.
That's a good point, kind of like a want versus a need.
Yeah, maybe splitting hairs there. I actually saw a patient recently with my fellow, and it was an interesting case where she was coming for a second opinion and probably needed a bilateral mastectomy. We might have been able to do a central lumpectomy on the one side, but really needed a mastectomy on the other side. And my fellow was thinking through it quite well, but she said, or we could get an MRI. And I love kind of walking people through the thought process of like, okay, so tell me how an MRI is going to change something. So the one side, there were extensive area of calcs. And I said, so what if the MRI shows a 2 centimeter area of enhancement and they're a candidate for a lumpectomy? Are you going to offer the patient a lumpectomy? Well, no. I do think it's also important to discuss with our trainees and our patients that MRI and mammograms are they're different, they're complementary, and oftentimes MRI doesn't negate the things that you see on mammo. It's not like MRI is this superior test that kind of negates mammography, which mammography at the end of the day is the OG.
Let's talk about nipple discharge, because I've got strong feelings, and they're probably 1973 feelings, but how many of you guys use MRI to work up nipple discharge in the absence of any findings on mammography or sonography?
Spontaneous or non-spontaneous?
Spontaneous nipple, what you'd call pathologic nipple discharge.
I do.
And how do you diagnose those papillomas?
Biopsy?
Ultrasound biopsy.
Maybe. It depends. Let's say you don't see anything on mammogram or ultrasound. You get an MRI that shows some non-mass enhancement by the nipple. You do a second look ultrasound. Oh, look, there's a papilloma. Then they do an ultrasound.
What if the MRI is negative? What do you do?
I talk to them about a ductogram or observation.
You don't just do a duct excision?
I'm about that too, but
I would
Dr.
recommend never doing a ductogram on a patient.
correct. I know patients hate it. So I'm like, last resort.
Yeah, but is it a useful test in 2026 anymore? I mean, I think that's really the question. When you have all of this, is it really a useful test? So are you talking about spontaneous nipple discharge from one duct? I mean, there's so many questions that haven't been asked in this scenario. So, Michael, how often would you order a ductogram? I mean, you'd have to really not like a patient.
I don't do ductograms. I don't do MRIs because if there's an MRI, they're going to get a biopsy. If it's small, maybe the biopsy takes care of it, but then I'm probably going to have to follow that back up with an MRI. So typically my go-to on a pathologic nipple discharge is to forego all of that and do a duct excision. And that usually gets my answer. Have I gone in before and not retrieved anything and found out later that it was 4 or 5 centimeters and more of a peripheral papilloma? Yeah, that's happened to me once or twice, but I'm been doing this for 30 years. So to me, it's worth just taking the duct out and being done with it.
What do you do with a 35-year-old woman?
That's a problem, especially when you're talking about preserving breastfeeding and things like that.
I mean, isn't that worthy of getting an MR to see?
Possibly.
Carla, what do you do? The question that Michael brought up, pathologic nipple discharge, ammo's negative, ultrasound's negative. What do you do?
I do one of both. I do MRI sometimes. I do the duct excision. Some of it's dependent on the patient. On the 35-year-old, Susan, I'm going to do an MRI. So I think it does depend on the patient's risk factors. I also kind of go over with patients, hey, I can do this surgery. This is probably going to find it. This is kind of quick. The MRI, here's the downside. You're going to have false positives, but we might find more things. So sometimes I don't totally give it back to the patient, but I do go through those things. But yeah, I like the duct excision for that because you get a negative MRI and guess what? That patient still meets criteria for surgery. So why not take them to surgery up front? And I've never had a situation where I've taken someone to surgery, not found something, and then something has happened down the line.
So Susie, when you do that surgery, how do you do it?
I will delve into that, but I first want to say, I asked the patient, how much does this bug you? And are we looking for this pathology on there if it would change their mind? And that's how I help decide with the MRI. And I agree, Carla, with the younger women, they're going to get an MRI. So I tell them not to express the morning of. I think that's really important to see how much people are fiddling with trying to express this. And so that I can identify the duct or ducts sometimes where that is at the time of surgery. And then I usually make a periorelar incision near where that is and then take the duct out.
So how far do you track it down?
I track it as far as I can get it to go. And then sometimes it falls into a normal fatty breast tissue. Sometimes it's super dense and it's a little bit more challenging. I don't know. It's not like I say a centimeter.
You try to use a lacrimal duct probe. If it's bloody discharge, you can usually see the blood in the duct, but sometimes it's not bloody and you can't.
Does anyone cannulate?
I do.
I don't.
If I'm doing a duct excision, that's how I do it. But I was big in the ductoscopy days, so
I was just going to reference people to a look inside the ductoscope.
I did it all the time. I became known in the city for nipple discharge, which is not a practice I ever wanted. Just filled. I was like, what am I, the nipple discharge queen here? We would also do it in the office.
How does that work?
It actually is very cool technology. And one of the coolest cases was we were doing wire lokes and putting the ductoscope in and seeing the mass and seeing the wire right through it. I mean, it was very cool stuff. Very cool.
Little pieces of cauliflower in the ducts that looked enormous on the screen. It is very satisfying.
It is. And it was almost a micro ductectomy because you dissected with the scope in and you were taking out such small area there. And in those days, I certainly had young women of breastfeeding age who went on to breastfeed after it. That was the goal, and we thought we would get there, and we did not. But it really was very cool, I have to say. Carla, you did them in training, right?
Yeah, I did them with Julie Morgentaler. So
yeah, it was cool. But believe it or not, we're just about out of time. Share one takeaway. Susie?
MRI is not a substitute for standard mammography and ultrasound. It can be an adjunct and be thoughtful about when you need it for your patient.
I love that. Ellie?
I am very surprised to learn that everyone doesn't use MRI as much as I do, but that's why we're talking and learning about other practices, and it's good to know that maybe I'm overutilizing it.
Michael?
I think MRI is a great tool that can be used selectively, like Susie was saying, that there are times to use it, and it's a real beneficial tool, but use it as you need it, not as you hope you may need it.
Need. We're back to that needing it. Carla, you get to close this out.
Well, and I would just transition to the next topic. I think that we as a group need to discuss screening MRI and just pointing out the difference between diagnostic, which is what we've really focused on here when patients have cancer, when they're getting neoadjuvant chemo, and there's a different thought process with screening. But I've got all sorts of opinions on that as well, so I'm looking forward to chatting.
So, to all of our listeners throughout the entire breast community, we're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie.
Michael.
Susie.
And Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.